Hi there, and thank you for joining us. This video picks up a few minutes into the session, so you're joining as Ginny Erboe, a registered nurse and educator with Hospice Austin's GIFT project, is already engaging with the group. Don't want you to worry, everything will still make sense as you go. And we're really glad to have you with us for this really important conversation today.
And then number 2 says, what or who supports you during difficult times? Your faith, culture, family, friends, pets. Well, that's pretty scary, Shelley.
So sorry about this. So sorry.
Their video,
Darling.
they're recording me. Okay. The next sentence says, what matters to me through the end of my life is, some ideas are being able to recognize my children, being independent, being able to spend time with the ones that I love. And maybe you've never thought of any of these things and need a little bit more time. Just come back to it. We'll flip to page 4 inside, and these are a little bit easier than the open-ended questions. So the first one says, as a patient, I'd like to know only the basics about my condition and treatments, all the way to all the details about my condition and treatment. And what's important is that you share with your loved ones your answers. Because I realized that I'm my mom's medical power of attorney, but I didn't know, does she want me to navigate all of her care? Or does she want to do that? Does she want to know if, if there's a matter of a prognosis that's days or months? Or does she just, want to go about living her life? So these are important things to kind of talk about with your family and friends. I've had married couples that their answers are absolutely opposite. And after 54 years, they know that they're opposite, but being able to respect each other's choices and maybe who they pick to be their medical power of attorney would also reflect on their choices that they have. Number 2 says, when there's a medical decision to be made, I would like my healthcare team to do what they think is best. All the way to the right is to have a say in every healthcare decision.
What number are you?
I am, yep, right here. Oh, I'm sorry. That's okay. The next one says, what are your concerns about medical treatments? I worry that I won't get enough care, all the way to, I worry I'll get too much care. On the top of page 5, it says, if I'm diagnosed with a serious illness that could shorten my life, I would prefer to not know how quickly it's progressing or my doctor's best estimation for how long I have to live. All the way to the right, understand how quickly it's progressing and my doctor's best estimation for how long I have to live. Next question says, if you were seriously ill or near the end of life, how much medical treatment would you feel was right for you? I would want every available treatment to extend my life, even if it's uncomfortable. All the way to, I would not want treatments that impact my quality of life in order to extend my life. The last one on that page says, where do you prefer to be towards the end of life? I strongly prefer to spend my last days in a healthcare facility, such as a hospital, assisted living, or a nursing facility. All the way to, I strongly prefer to spend my last days at home. And then we'll just go to page 6 and do those last 3 sort of sliding scale ones. If you weren't able to speak for yourself, would you want people to follow all of your wishes or do what they think is best in the moment? I want the people I trust to do exactly what I said, even if it makes them uncomfortable. All the way to, I want the people I trust to do what brings them peace, even if it's different from what I said. And I actually did meet a little lady and her daughter who I talked to the patient in the bed and she told me what she wanted. And then the doctor came in and her daughter was there. And the daughter made choices for her that were not what she had told me. And so I kind of leaned over and said, well, that's not what we talked about. And she said, no, it's okay. I want my daughter to make the decisions and I'll do what she wants if that brings her peace. So, everybody's different, right? That may not be you, but there are instances where that is true for somebody.
She said that to you towards the end, the one that was dying?
The patient told me, that's okay. I'll go through this other procedure, even though that's not what I want. Yeah.
Even though it was written down some other way, she was able to say that.
Well,
verbally.
so tell me your name.
Pam,
Pam. So Pam's asking some really good questions. So this information, as long as we can make our own choices and be verbal about it, we have that right? Nobody can interfere with our choices. Most of this is important, and the conversations we have are really important when we cannot speak for ourselves. So this lady was able to speak for herself. She told me she didn't want to do any of those things. Her daughter was there and the doctor came in and offered some interventions. And the daughter said, oh yes, we want to do that. And so the mom said, okay, I'll even though that's not what she wanted to
and who
do.
did she say that to?
Because I asked her, but the daughter was telling the doctors, yes, we want to do that.
So in other words, it can be casual, it can get changed, even though it's all written down another way.
Well, as long as she can make her
I
own choices.
understand.
Yeah,
I understand.
absolutely.
That's good enough.
Yeah.
That's good enough.
Yeah. And so, yeah, these are decisions that we write down that are most important, and it's very fluid. So we can't exactly know everything that may occur to us. But it's important that we have these general conversations, especially as we're healthy. And I'm guessing most of us are pretty healthy. But as we start to decline and get more comorbidities or diseases, then that's when we may decide that we want different things. Yeah. Okay. The next question says, when it comes to sharing information about my health with others, I don't want those close to me knowing all the details. All the way to the right that says, I'm comfortable with those close to me knowing all the details about my health, or somewhere in between. And then at the last question says, when I die, I want to be alone. Or all the way to the right, I want to be with other people. And I've seen this play out. Maybe some family is sitting vigil with their loved ones as they're dying, and they've been there 7 days, 24 hours, and they step across the hall 6 feet to grab a cup of coffee, and that's when their loved one passes away. And they're devastated because they weren't there. But most likely, if that has ever occurred to you or occurs, it's because our loved one feels like they wanted to protect us. They wanted to do that in their own space, and they didn't want their loved ones to witness their last breath. So just know in your heart that it's most likely for a reason, if that's ever occurred. And then also know if you've ever had to make choices for a loved one where it feels like you were the one maybe killing them or making decisions for their death. That's not true, right? Their body in decline and their passing was from conditions that were going on in their body. And it may feel like we had to make some really hard choices, but it's not necessarily in our control, right? It's something going on in their body that they died from. So this is a great little resource. On page 7 are also some icebreakers. So if you need to have a talk with your family, you can simply say, we went to an amazing conference and these two beautiful women came and talked to us and gave us homework, and now I have homework. I'm, 62 and I haven't had homework in forever. But, or you could simply say, we haven't talked about this, and it's important for me to know what you might want if you were in a car wreck on 35 or Mopac, or if you had a stroke. So, I've been doing hospice work for 25 years. I will say after the pandemic, the trajectory or the decline process that we're seeing in reality is a lot shorter than what I used to experience before pandemic. Whatever those reasons may be, it's just a matter of reality. Things like stroke, cancers are very rapid at this point in time. Some people are even calling it like a turbo cancer. So where maybe somebody was diagnosed with a cancer before pandemic, they would go through treatment, they would progressively have a decline. And maybe years after their cancer, then they may opt to start hospice. Now what I'm seeing is a diagnosis of a cancer or disease process, a very rapid sort of treatment, and then sharp decline, and then a very quick admission onto palliative or hospice care. We'll definitely talk about what those services are, but it's a much shorter time period that we're experiencing our decline.
Can you just give a comment as to why you think that could be possible?
So Pam's asking, why is this more of a reality? I don't know whether it be, the COVID infection or any treatments or anything like that, but I just know that there's a lot more clot situations going on throughout our body. And then the disease progression is just very rapid. So we just need to get prepared, and every day is a blessing that we wake up, right? And get out of bed, however fast or slow we can, and to recognize that, right? So my friends always ask me when I go to a party, oh, what do you do? And I say, oh, I'm a hospice nurse. And they say, oh, that must be so sad. And it's actually not. It's a true blessing to be able to recognize how precious each day we have and the miracles that we can experience. And so when we recognize that, that just makes every day a little bit brighter. And so really that's what this work is for. And also working in hospice, it's a true honor and blessing. And just a reminder that life can be so short. So that's a wonderful resource. I'd like to go into just talking about medical interventions on a short note. Let me see. I don't have a clock here.
It is 12:34.
Okay, thanks. So in your little stapled packet of information, we did a little summary. So this stapled workbook on page 3. So there is a wonderful resource that you can opt to look for online. We no longer have them available at Hospice Austin at the minute. So it's a wonderful book called Hard Choices for Loving People. It's written by a hospice chaplain named Hank Dunn. They're anywhere from like $3.50 to $7 online if you'd like a resource. But we did
repeat that. Hard choices.
It's at the top of page 3.
Oh, okay.
You can highlight that. Hard Choices for Loving People by Hank Dunn.
Okay.
So it is a wonderful, sweet little book. We did do a sort of the Cliff Note version of it to talk about a few things. The most important things about learning about interventions, and the reason why we want to give you sort of a baseline foundation today, is because it's best to learn about something when you're not in a crisis, or say, for instance, you're in the hospital bed or your loved one is, and the doctors come in and spit out a bunch of things about what's going on in 5 minutes and ask you, do you want antibiotics, a feeding tube, a catheter, all sorts of different interventions. And that's not the best time to sort of to learn about those things. So we want to provide a sort of basic foundation about some of these interventions. If you have any questions, feel free to ask. So the things to think about medical interventions, there are always pros and cons to interventions. And a lot of times at the hospital, they don't really explain any of that, right? They focus on, here's what we've diagnosed our loved one with, and here's how we can fix some of these things. And do you want to do it? And they don't really tell us about what the negative side may be for some of those interventions, or focusing on what's important to you. What are your goals? Are your goals to, be more comfortable? Are your goals to focus on quality of life? Are your goals to live as long as possible, even if you're connected to machines and aren't aware of anything going on? So really thinking about what's important to you at that phase of your life, given what's going on in your body. So questioning physicians is a good thing, right? Asking questions. And sometimes we don't even know to do that or what questions to ask. But doctors are getting better about having conversations about finding out what's important to us before we proceed with massive surgery, right? So I am starting to see that more and more. In medical school now, they actually have a whole semester on the art of communication. Wouldn't that be wonderful if every school train of thought, high school had a whole semester on the art of communication, right? We need that. Maybe that's what our next workshop should be on, Johanna, the art of communication. So interventions have a time and place, absolutely. You can also try interventions for a period of time, like a time trial. So for my dad, for instance, maybe we did a feeding tube for him and we said, okay, in 3 months or 6 months, this date, if you're not, if his quality of life has not improved or it's not what he wants, then we would consider stopping that intervention. Sometimes starting an intervention and stopping it is a lot harder than actually starting it at all, but at least that would have been something that we could have done to honor him. And I wasn't aware of that at that point in time. So let's talk about cardiopulmonary resuscitation. So that's CPR out in the community. So probably you guys have seen it on TV, movies. Somebody has a heart attack or stops breathing, they fall to the floor. We do chest compressions on them and they pop up and they go about their business. It's not that pretty. But CPR is designed for if our heart stops beating or if our lungs stop breathing. And it is an intervention that we could do out in the community that include 4 interventions. Chest compressions, which is actually utilizing your breastbone to beat your heart underneath, right? So we're pressing on your breastbone to beat your heart to push blood throughout our body. Some sort of rescue breathing, that's up to the rescuer now after COVID. They say the most important thing is circulating the blood around. But the rescue breathing is up to the person rescuing us. So that could be mouth to mouth, or if they show up with like a mask and a bag, then they can blow air in with this, it's called an ambu bag. It also includes pacing with a defibrillator. So I think there's a defibrillator out in most main centers, or at churches or in the shopping center now. You'll see a defibrillator. If anybody ever goes down on the floor, somebody should go get a defibrillator and put it on them. It's real easy to do. Anybody could do it. They show you when you unzip it, they tell you where to put it. You basically want to get the heart in between the 2 sticky pads. whatever, it doesn't matter if it's here to here or front to back, however you can do it so that it's reading your heart in between. It can shock a heart back into a normal rhythm, or it can pace the heart if it needs to be paced. I have a friend that actually decided he was gonna start working out again and went to the gym and was running on the treadmill. The guy, he actually had a bad heart rhythm, and he was working out next to a cop who was off duty. They immediately started CPR. If they had only gotten the defibrillator that was behind the desk and put that on and shocked him, he would be with us today. They did not do that.
He died.
He died. He died on the way to the hospital. They were doing CPR, but he needed his heart shocked back into regular rhythm because he was an otherwise healthy. I think he was 52 at that time.
Can anybody do that?
Absolutely, yeah, put on the defibrillator. Yeah, and it talks you through it. You turn it on and it tells you, okay, reading the person's heart rhythm, and then it'll tell you when to not touch him if they want to shock, if it says, oh, we need to shock this person.
Is that what that shocking thing is we see is with the defibrillator? So
Absolutely.
anybody can do the.
Anybody
shocking
can
with the
do,
defibrillator?
anybody can use a defibrillator, even if you haven't been trained. Yeah, so if anybody goes down, that's what we should be thinking is go get a defibrillator and see, as well as calling 911. But that alone could have saved my friend.
Now, what was the thing you mentioned before? Some kind of bag.
Oh, that's like if you see it on TV, ambu bag for breathing.
Ambu, A-M.
BU, and it's just a mask and it's connected to a bulb. And you put the mask over their mouth and it blows air into their lungs. So most EMS or, trucks have them.
Yeah, but why wouldn't the EMS guys have used that defibrillator instead of doing chest compressions on the way to the hospital?
They connected him to it, but by then it was too late. Yeah, he had been down too long.
Are defibrillators something that you can just go buy at a medical supply?
Pam's asking, can you carry your own defibrillator? Absolutely, you can now, because a lot of kids on the field that they have just this fast rhythm. And that's why a lot of times, a lot of the young athletes die on the field and all they needed to do was be shocked. So it's a hereditary genetic, bad rhythm for hearts. And all they needed is a defibrillator implanted. Yeah.
This is not common. People don't ever talk about it.
Well, and it doesn't happen very often.
Yeah.
Yeah. So CPR out in the community is not as glamorous as we see on TV. It may or may not be a decision that you decide that you would like to have in the future. But for most people, if you're fairly healthy, then there is a chance for CPR to work for us. So it's when we age, and my age keeps getting higher and higher. When I first started, I think it may have been 60, and so now I'm up to 90. So as we age, there may be a point in time when you decide that you would not want to be resuscitated, that you've had a complete life, and that you're at peace with whenever it is time for you to leave this world. So you would want an important form called an out of hospital do not resuscitate order completed. We will briefly go over that at the end, and if anybody wants more information on that at the end, then we'll dive into that a little bit more.
And do you have that form here?
Yes, we provided one for you. So some interesting facts about CPR is that in most cases, patients with multiple serious medical problems, terminal illness, or who cannot live independently. So if they're in some sort of assisted living or nursing home, they survive less than 2% of the time with CPR. And they don't tell you what kind of condition that person ends up being in. So as we start to have those situations, that might be an appropriate time to be a do not resuscitate. Possible burdens of a successful CPR include fractured ribs, punctured lungs or organs, brain damage, depression, never regaining consciousness, being connected to machines, or possibly reducing the chance of having a peaceful death. So CPR is useful out in the community, but there may be a point in time when you decide that that's not something that you would want to to undertake and possibly forego. What questions do y'all have about CPR? Anything?
I mean, do you think it's common, most people say do CPR?
So unless you have a do not resuscitate completely filled out appropriately with the doctor's signature on it, then everybody is a resuscitate. So you have to have that do not resuscitate in order for that to,
But CPR is considered resuscitate?
yeah, CPR is resuscitation. Cardiopulmonary resuscitation.
But when a lifeguard just pulls you out of Barton Springs and, they just give you CPR and you're gonna be okay.
Right.
If you had filled that out because, you were scared.
Well,
about
most
big
people
stuff.
wouldn't, most people, so Pam's saying, so correct, so CPR was designed in the sixties for either a drowning, electrocution, or maybe a simple heart attack for somebody who's otherwise healthy, right? And we're hoping to bring them back to their current state of health with a little bit of help from CPR. But when we are terminally ill or nearing the end of our life, that's not really a time for CPR.
Gotcha.
So if you have a situation, like my mother's out and about and she falls over and I'm not there to show her do not resuscitate. And the ambulance comes, is there anything like a bracelet or a whatever so that all the time people know, like, or they do not resuscitate 24/7 everywhere you go?
So Daphne's asking about, like, her mom has a do not resuscitate order. So how can she be identified if she doesn't have it on her? So there is a medical medallion that you can purchase on the Texas Department of Health website. You have to go to the Texas Department of Health website. I was seeing if I had my example with me. So there are 4 websites that you can purchase one from. They will want to see a completed DNR. And then they will mail you a bracelet or a medallion that you can wear. They're $25 to like $300+ You can get one with bling on it. You can get it, bedazzled or a simple silver one. So there's lots of options to make them pretty, but there is a specific one that says that you are do not resuscitate, and first responders will know to honor that a DNR somewhere. Now, does it always protect us? No. I mean, we're doing the best that we can so that the community knows what we want, right? I've had examples where people said, well, we had this and this, and she was still resuscitated. We're just doing our best to try to get our wishes honored. Did you tell me your name?
Comment, I've actually heard of people having that tattooed on their chest.
Yeah, tell me your name.
It's legal.
What is your name?
CK.
CK?
Initial CK, yeah.
Okay, great.
But my question, you're probably gonna get to eventually, so you don't have to answer now. For those of us who are solo folks, you stick these on the refrigerator?
Yeah, so we were talking about solo agers. Yeah, making sure your wishes are desired and written out so that your healthcare team knows. You could carry the DNR on you. You can wear a bracelet. You can have your wishes written out so that if you went to the hospital and they locate that information, then they'll know what your wishes are. So yeah, it'll be important to have that written out.
But where would they go look for that information?
So some of the EMS will look in some of our belongings. There is an app on your phone that you can scan some documents, and it's actually stored on your locked screen. It's called My Directives. That's on Apple phones. I don't know about Android phones, but I think there is a directive website or an app that you could put on your phone. So EMS and firefighters will look there sometimes.
Inside of the front door?
Yeah, and
Have they broken it down?
yeah, so the other thing is just to have a packet of information, maybe the folder with your directives in it, anything that like your important contacts, your driver's license and insurance cards, your medical providers, and your medications, dosages, frequencies, and even what they're for. And that little bit of information will ensure that you get the most efficient care at the hospital, right? So that's what all of that packet of information is for, so that way they know more about you when you come in versus having to guess or see if there's something in the hospital records.
I will add that there is a service that the Travis County Emergency has, it's called Vital Life. Or a lockbox. A lockbox, if you call their community education division, they will educate you about the lockbox so that they don't have to, beat your door down.
Oh, for the key, and they have a master key, so
Correct.
they can get your house key and they can go in your.
Correct.
I
And the
didn't know.
DNR is part of,
I didn't know what's to do.
Oh, wow.
and the DNR is part of the packet, like the Vital Life. In addition to identifying medications that you're on, conditions that you have. So that's very useful. And the way that they know that you have it is there is a decal that you place on your door. So that's the signal to emergency responders that you have that information in there.
You
It's
say
called
Vital.
Vital, VIAL.
And this is for Travis, from Travis County.
Yes,
The health department.
the Travis County Emergency. It's the EMS that picked you up, so, I can also send that information. We will be sending a short survey after, the program. So we can include that information for everyone.
Great, thank you. So moving on to feeding tubes about artificial nutrition and hydration. So there's a couple options. Maybe we need just a little temporary fix while we have some pneumonia or maybe an infection or something at the hospital. There is a way that they can insert a feeding tube down your nose into your stomach, and that's called a nasogastrial tube or an NG tube. It's a very temporary measure. Most people don't like to have it in. Sometimes they have to be placed in mittens or restraints so they don't pull it out. But you can get nutrition, hydration, medications, and even connect to suction if you have a lot of nausea. They can remove the contents from your stomach so that you're not nauseated. And that's called decompression. So an NG tube is a temporary measure of some feeding tube type. A more permanent solution is having a G tube, which is a gastrostomy tube placed in your stomach, surgically placed. It's a more permanent sort of long-term solution. And it's a cool little valve that goes to your stomach, and you can do the same thing that you did with this other tube: nutrition, hydration, medications, and you can also decompress utilizing that. So one thing that I learned that I didn't realize through my nursing school and several years of being a nurse is I thought that anything, if it was placed artificially into our stomach, that it was good there. There is such a thing called aspiration pneumonia. Have you guys heard of that?
No.
It's where you actually cough up materials from your stomach into your lung space. And as we age and sometimes have a dementia or illnesses, we may start to do this. It's called aspiration pneumonia, and we may start to have that happen more frequently. Even if we use a G tube or a tube down our nose to put contents in our stomach, we can cough those up. So if somebody has like a dementia and they stop eating and they put in, or they start to have these pneumonias, just because we put a G tube in to provide nutrition, they're most likely going to still have that aspiration pneumonia come up.
And what are you saying about the aspiration pneumonia?
So every time somebody gets an aspiration pneumonia, most likely they end up at the hospital. So it may be a period of time where you do it once a year, then twice a year, then 4 times, and even on down to every other week. So some little Alzheimer's patients or dementia patients may end up at the hospital, either with a UTI or a pneumonia. And at some point in time, families may decide to no longer treat that infection and allow them to pass from an infection.
You can pass from there?
From an infection, absolutely,
Yeah.
yeah. So one common thing that we hear is, well, if my loved one's not eating, then, you know, we're just letting them starve to death or die of dehydration. And so as our bodies start to shut down, there are amazing things that our bodies do. So in regards to the most common one that I hear at the hospital is, you know, my loved one's dehydrated, they need IV fluids. Well, as we are entering the dying process, they drew labs in a research study on patients that did not receive IV fluids and drew labs on patients that were dying that did receive IV fluids. And they found that the ones that had IV fluids, their bodies did not know they were going through the dying process, and their bodies did not produce endorphins. So those that were allowed to enter into the dying process without IV fluids or nutrition or hydration being artificially placed there, knew that they were going through the dying process, and our bodies naturally produce that chemical hormone that gives us like a euphoria, sort of happiness feeling. And so, you know, our bodies are so amazing that when we're doing that, we don't realize that we're starving or dehydrated. Another intervention we may hear about are ventilators. So a ventilator, probably that's one thing that we did learn about through COVID, is a machine that if our lungs are not breathing for us to the best of the capability, we may be placed on a ventilator. A ventilator has a great purpose, especially for surgeries, because we use ventilators when we most likely have a surgical procedure, so that we can go under and have our procedure done. Ventilators are useful if our lungs have capacity to return to a healthy state. If we have lung issues, a cancer, or a hardening of the lung called fibrosis, being placed on a ventilator is not going to recover our lungs, and there's no place for us to be removed off of that machine and be able to breathe on our own again. So at some point in time, if we are entering a phase where our lungs are just not healthy, that most likely is not a time to be placed on a ventilator machine. A ventilator involves putting a tube down our throat into our lung space, connected to that machine. Most of the time when we're on that machine, we are sedated, or restrained, because otherwise we'd be trying to pull that tube out of our throat. If we need it for longer than 2 weeks or a more permanent solution, that's when they do that surgical tracheostomy and they place a little tube down our throat here and connect us to the ventilator machine. Dialysis is when our kidneys are not working and we're not producing urine or removing toxins from our bodies. So dialysis can be a temporary solution to let our kidneys improve, or it could also be a lifelong chronic issue. So most of the time, dialysis patients will go to the dialysis center 3 times a week for about 4 hours at a time. Some people will actually do a procedure where they connect themselves to an abdominal peritoneal dialysis, where at night when they're sleeping, they wash some fluid through their abdominal space and remove toxins that way. And that's called peritoneal dialysis. So a lot of times patients that we have come on services at some point in time will decide that dialysis is not a way of life for them and they don't have any quality of life, so they'll stop their dialysis treatments. It's a very peaceful process, but it takes a lot longer than most people think. It can take 2 to 3 weeks for them to kind of drift off to sleep after they stop dialysis. But it is a pretty peaceful way to go. One thing that we were talking about, Pam was asking about antibiotics. So antibiotics can treat infections, but at some point in time, if our loved one keeps going back in and out of the hospital for either a UTI or a pneumonia, at some point in time, we may decide that that they no longer want to do that, or it's not beneficial. And whether that be 1 or 2 trips to the hospital, or maybe 10 or 12 trips to the hospital. But at some point in time, you or your loved one may decide that they don't want it to be treated with antibiotics and just to go ahead and pass from an infection. And that used to be called the old man's friend. Pneumonia was known as the old man's friend, and we do have quite a few people pass from pneumonia every year.
But at what age can you not have the preventive medicine anymore?
Well, you can continue, and Renata's asking, what age can you not have preventive medicines, right?
No, I mean for specifically for pneumonia.
You can continue to go in and out of the hospital as many times as you like. I mean, the
No, I'm
doctors.
talking about preventive when you're still healthy.
Uh-huh.
Like if you're in your 80s or close
How
to
do we
that.
keep from getting pneumonia?
Yeah, yes.
How
that's-
do we keep from getting pneumonia when we're
Yes.
in our 80s?
Oh, so,
That's what I mean.
Renata's asking, how do we prevent from getting a pneumonia? I mean, being active and moving around, a lot of times people get it when they're in bed. A lot, and they're not moving, moving around or as active. Or if they sleep laying flat, they may regurgitate or aspirate some of those things. It also may just become a bodily function where the valves in our throat and esophagus, they just don't close right. So contents from our stomach can go up our windpipe and then into our lung space. So.
But that doesn't answer my question. Should you stop getting preventive medicine when you're healthy?
Well, I mean, I think you would.
Like getting the shots. Getting the shots to prevent to get pneumonia. That's
Yeah.
what I mean.
Well, so those are questions that you should ask with your healthcare provider,
Well, I
when.
just wondered if you knew.
And if there's only one shot, once you get it, it's good for life. I think she's talking about vaccines.
Well, I mean, no, I mean, every year they offer pneumonia vaccines and they offer
But
chickenpox.
You don't
And
have to-
Yeah.
It's a one and done.
they offer it every year, so it's an annual thing. So I think those are choices that you have to just decide with your healthcare team, your healthcare providers, on when you feel that that's an appropriate measure or not. Yeah, because there's lots of different routes to go for sure. So that puts us in a little space and time. Let me see what time it is. Do you guys want to stand up and just stretch? Does anybody need any water?
I think we're out of water.
Oh, you're out of water? Oh, Matt. Let's take about 5 minutes. Do you want 5 minutes to maybe stretch, go to the bathroom, get some water?
When is it supposed to end? What time?
2 o'clock.
Would y'all like some bottle one?
Sure, thank you.
Right.
Yeah, she definitely really got a chance. Oh my gosh. Oh, no, there you go. Pneumonia.
Definitely more in the back. Okay.
Yeah, I don't, everybody's different and whether or not, they offer that. Yeah, those are
But I mean specifically, there's.
Weird.
Yeah.
Well,
Yeah, and whether or not they work, I don't know.
Well, I don't know either. I think it just. Okay. All right.
Yeah, I still got sick.
I don't have one in my bag on.
I can take you. Yeah, that'd be great, because we do. That's our resources. That there, the staff.
Okay.
Oh, okay, great. Okay. And then, yeah, if you'll, write your name on the back. Oh, great. Shirley, do you want information? Oh, I guess as long as that. Get some papers. I don't know what happened. No. There's just water everywhere. Yeah. Thank you.
Yes. But I figured
Well, I gave them 5 minutes. Do you want to know that they want to know a lot about this? That'd be great, and then that'll be 20 minutes to do direct ones.
Perfect. All right, so, is this
That table where they're standing over there. All right.
Quick question. So I don't know. What are you talking about? Yes. So I don't get up until. I just waking up.
I know, I need to.
But I'm just wondering. Keep up socialization. Grapes. Keep up that was big stress. That was the best
Palliative.
information rather than emotion. Like, yeah, no, it can be. Somebody finds so. That's the only.
I need Okay. Find our seats. Find our seats. We actually have a wonderful surprise. Dr. Sandra Frelson is here today. She's our chief medical director at Hospice Austin. But she had a break in her day, so I'm gonna let her talk to you guys about hospice and palliative care. And then we'll talk about directives after she finishes. So if we'll give her your attention, and then you can also ask any questions. We do have those two brochures, if that's helpful. To refer to.
Yeah. Well, good afternoon. For a second, I forgot what time of day. Sure. Probably good for the recording too. So I'm so happy to be here today, and I really want to thank all of you for being here and for thinking about advanced directives. I know Ginny is going to get into some more of the meat of it in a bit, but it's such a gift that you can give to the people who care about you to think about these things when you're not in a crisis, and can really think about what your wishes would be for different situations, and hopefully to communicate that. We see so many families who both have that information, and it's so helpful. It really relieves the stress of being in the crisis if that time comes. And then people where they didn't have any conversations about it, and they do their best to make decisions that they think are what the person would make, but having any concrete information you can give them about your wishes really helps them navigate that situation with their healthcare team. So thank you. So Ginny thought it'd be helpful if I talked a little bit about hospice and a little bit about palliative care. I've been at Hospice Austin for about 12.5 years now, and in the field for another 8 before that. I think hospice is really such a gift that people can have, to have that time to do the things that matter to them, to have their symptoms controlled and be comfortable, and to spend time with the people they care about. And it's not possible in all situations. Sometimes things happen too quickly, and you all have probably experienced losses. Some of them might have been quick, and some of them there might have been a little bit more time. And so let me talk a little bit about the hospice benefit. And what we hear from so many people is they wish they'd come onto hospice sooner. And so as you're thinking about your own health and people you care about or know, just kind of keep these things in mind. So hospice is a Medicare defined benefit for people with 2 things. One, when their healthcare team thinks their prognosis, how long they're likely to live, is likely to be less than 6 months. No one has a crystal ball. We don't have to, guarantee it. There's no penalty if people live longer. And in fact, we have many people who live longer than that. And that makes me very happy, because when the average length of stay for people is less than 14 days, and that means that it is still in that kind of crisis situation. And that's a really short amount of time for people to get to know their hospice team, for the team to get to know them, to help them get their symptoms under control if they're not already, and to address any life completion tasks, either practical, like arrangements, or emotional, spiritual. And the more time people have for those things, often the better. The other thing that people need in order to qualify for hospice is that they're not pursuing any therapy where the goal of it is to make their life longer. And so usually that's things like chemotherapy, dialysis, certain other therapies. With Hospice Austin, we try to let people continue to do things that will help their comfort or help serve their goals. And that might include things like continuing to see some of their doctors in the clinic. It might include doing blood transfusions if they're having fatigue or trouble breathing that get better with transfusion. It might be radiation, help with painful involvement of cancer in the bones. And not all hospices do that, so that's just something to kind of tuck away. But we really try to tailor the therapies that people get to what their goals are and what will really benefit them. When people come on to hospice, there's a number of people in the team who help take care of them wherever they are, whether that's at home, in a skilled nursing facility, in a assisted living, or I'll talk briefly about our inpatient hospice unit, Hospice Austin's Christopher House. So the team includes a nurse case manager, a physician, it might be a nurse practitioner as well, social worker, chaplain, home health aide, clinical nurse, clinical nursing aide. Gosh, I could not think of that for a second. And then a volunteer. We have amazing volunteers who work with us, who visit people in their homes and help with socialization. They might spell their caregiver so they can run to the store or something. And we have aides or volunteers who do pet therapy and music therapy, or just play music and massage and all kinds of things. They're really a wonderful group. And so if somebody, one thing I want to mention is, if hospice is ever something that you're thinking about, you can always have an informational visit just to get information. And sometimes people will talk to more than one hospice because they want to find one that's the best fit. Two ways to choose a hospice. One is to ask someone you know who's had an experience with hospice, if they have a hospice they would recommend, or sometimes one they would not recommend, and that's helpful intel too. The other thing is Medicare has a website called Hospice Compare, and it's hospicecompare.gov. Actually, now it's carecompare.gov, sorry. And you can look at different hospices and see, is it nonprofit or for-profit? There are some for-profit hospices that provide excellent care, but statistically nonprofit hospices like Hospice Austin tend to provide better quality care. So it's just something to keep in mind. You can see how many patients they have. You can see their quality scores. And right now there's one, kind of two main quality scores that are published. It's kind of, it depends. They're usually quarterly, but some of them only update every other year. One is the Hospice Care Index, HCI, and that's a scale of 1 to 10. And then one is a 5-star quality score, and where 5 is the best and 1 is the worst. And the other thing is there'll be a new type of score that goes into that's starting in October. So I'm not going to get into that, but Medicare is trying to keep these things updated. And do you have a question?
Website
carecompare.gov. Yeah. Mm-hmm. Yeah. Yeah. And so that's a good way to kind of see what people's quality scores are like. Yes.
Really basic question. Is it really true that hospice does not cost money?
It's a great question. So the question was, is it really true that hospice does not cost money? So Medicare expects hospices to cover what they call virtually all care. And so that is the actual hospice services themselves. It should be all medications that are related to the person's hospice diagnosis or their symptoms. Hospice Austin interprets that pretty strictly. So we cover pretty much everything except for glaucoma drops and some skin stuff where, and that would just be covered however it was before people come on hospice. There are other hospices who are much looser about it and cover fewer things. Hospice also covers any equipment that's needed and any supplies like wound care supplies or briefs or diapers, chucks, things like that to provide care for people at home. And
hospital beds?
Yes,
and
hospital
machine
bed,
beds that have to go to the
oxygen,
house?
wheelchair, walker, overbed table. I'm trying to think of other equipment that's real common. Oxygen, definitely.
So do they pay for the hospice workers who are coming to the home to help the person?
Yes.
We didn't hear the question.
Does Medicare pay for the hospice workers who come to the home? The answer is yes. One important thing to know about hospice is that while the care is available 24 hours a day, there's not someone in your home 24 hours a day. And so it really depends on the caregiver's family and sometimes paid caregivers to help that are private paid by the patient and family to be with the person 24 hours a day. But it's really helpful. The nurse comes in usually at least once a week. The aide might come 2 or 3 times a week, depending on what the needs are. And then the social worker and chaplain call or come usually around monthly, but it kind of depends on what your needs are and what you know, what you want. Sometimes people want more people coming through their home, and other times they're like, I want the fewest people possible. I have things to do, and so forth. But let me just say one other thing. At Hospice Austin, our physicians and nurse practitioners make home visits, which is not that common for hospices. So that's something to ask about. And one really helpful thing is that someone's available 24 hours a day by phone, and you can even have a nurse come out to the house in the middle of the night. And that's often something that helps people make the transition to hospice, is when they have a crisis and they're really, they don't really want to go back to the hospital, but they feel like it's their only option. And then that's a great time to think about bringing hospice in, so there is an alternative. Do you have a question?
You must have covered.
Okay, perfect. Some other times to think about hospice are, and really hospice is for any diagnosis people might have. Sometimes people think about it for cancer, but heart disease, lung disease, neurologic diseases like strokes or dementia or ALS, Lou Gehrig's disease. There's a lot of other kinds of diagnoses people might have that would bring them to hospice. And times to think about it are sometimes people's medical team will bring it up. And hopefully that's the case. But I know that sometimes doctors don't like to have those bad news conversations. And so sometimes patients and families are the ones bringing it up. But if people are kind of in and out of the hospital and they're just not getting better the way they had been, and they're starting to feel like they don't really want to go to the hospital again, that's the time to kind of think about hospice. Or sometimes people are in the hospital, they go to rehab, they seem to be getting worse, not better. And that's maybe a time to think about it. With something like cancer, it's sometimes easier to think about the right time for hospice, because it's usually when the disease is not responding to the treatments like it had been. Either there's not another treatment that could be offered, or the treatment that is offered, it's discussed that it may not really, the chance of it helping are relatively low. And people are kind of weighing, is this the right thing to do, or should I just say that's enough? So those are just some general guidelines. The other thing is, if people are losing weight, a significant amount of weight, or losing function, things that they could do for themselves, they can't anymore. Or if they're having a lot of symptoms, and I'll talk about this again when I talk about palliative care, but if they're having pain that's really hard to control, or trouble breathing, nausea, vomiting, those are not necessarily things on their own that would bring someone to hospice, but sometimes their team will say, you know, I think there's a lot of restrictions now on pain medication usage. And when people get to hospice, we are able to be still very careful with those medications, but we don't have the same restrictions from the DEA and kind of licensing bodies. Yes.
So back to the solo question. Can a person who bring up themselves to hospice?
Yes.
And just be totally, because there really isn't anyone?
Do you mean like someone who does not have a caregiver?
Oh.
Absolutely. Yeah. And usually then the team will work with them to figure out a plan. If you're on your own without caregivers, what would be the plan if you're not able to care for yourself? And usually that means either sometimes bringing in a bit of a patchwork of friends or neighbors and so forth, or sometimes it's, if this family who's out of town, figuring out what plan with them, paid givers, or sometimes people do go to a skilled nursing facility, nursing home if if that's really their only option.
Last bad question, what if
Uh-huh.
there really isn't any money?
Yes, very good question. And what if there's not any money for that? And it's really, I mean, our system right now, it just doesn't work very well for when people's goal is to keep it home, and Capital City Village is a great resource for that. But when people are acutely ill and they're really needing 24-hour care, it's hard because 24-hour care, when you pay for it, is very expensive. And sometimes people can manage it if it's for a short time, but if it's going to be longer, it's just not possible. So one thing is that sometimes people will then qualify for Medicaid and be able to get care through Medicaid.
Well, what if the person just decides they're just kind of done, and they
Yeah.
want to go to hospice, can they do that? On their own,
And say that again. Yeah,
on their own, make that decision without all the, whatever all these things are.
Like without talking to their doctor or something like that, you mean?
The
or-
doctor, sure, but
Yeah.
I mean, there is Medicaid.
So yes, but then it's good to have a plan for if they really can't take care of themselves anymore. And then we've cared for some people who, for them,
But I thought that's what you're going to hospice for, is to be taken care of.
yes, but there's not anyone in the home 24 hours a day. So like if somebody is bedbound and they can't get up to get water or something, or if there's a fire, they can't get out of the building,
Understand.
we would want to make sure they were safe.
Okay,
Yeah. So I'd say it's something that we need to work through.
but it goes on.
Yes, for sure. For sure.
So I
Yes.
think a piece of it is still there's this sense of going to hospice
Mhm.
in terms of it being a living in,
Right,
but you said, and I'm the understanding, it's not always a living in.
Right.
It's it's a status, really. So do you have a sense of like what proportion are hospice in their own living space?
yeah.
Versus in your actual
Christopher House.
community?
Right.
Yeah.
So it depends on the hospice, how many people they care for in a facility versus at home. And, right now, like we care for people, about 30% of our people are in a facility. And we are actually trying to work more with facilities, so it's maybe more like 50-50. But there are some hospices where almost all of their people they care for are in facilities. So it does vary. So that's something just to keep in mind as you look at a hospice. I did want to mention Hospice Austin's Christopher House. So there's a level of care for hospice called general inpatient care, which is when symptoms can't be controlled at someone's home or sometimes at a nursing home, but usually more if they're at home. And usually it means that their oral medications are not controlling their symptoms. And that could be the symptoms I mentioned earlier, pain and trouble breathing, nausea, vomiting. Those are the most common ones. Agitation at the very end of life is very common. And most times we're able to control those symptoms at home, but if not, Christopher House is a really good option. And if you haven't been there, I encourage you to try to call and set up a tour. It's really a beautiful place. There are private rooms. They've got a little outdoor patio. It's just a very peaceful environment. There's a beautiful garden and fountain, and there are people who bring therapy dogs through and musicians playing, and there's always delicious baked goods that somebody brought. And there are, in each room, there's a couch where people can stay overnight. So there's no restrictions on visitors. People can have their pets visit. And the care there is just really excellent. And it's
Isn't it full?
beautiful.
Time?
Not always. I didn't look to see. We have 14 beds, and it's usually, it depends on the day. Sometimes it is full, but usually a bed will open up within a day or so. And sometimes people come to Christopher House from the hospital. Sometimes they come from home. And one other level of care I wanted to mention is respite care, which is one of the key parts of the hospice benefit, which is up to 5 days at a time. Usually it's in a skilled nursing facility where if the caregiver needs a break, or if, say, the caregiver has their own medical illness they need to take care of, or the family is going out of town for a wedding or something, and so you kind of prearrange it. It's not meant to be an emergency, but it's up to 5 days. And again, there's no charge for that. That is provided as part of the hospice benefit. Yes.
And I also want to speak to, I guess, solo agers, as someone mentioned, if they don't go to disparate house or they're not in a facility, Hospice Austin does collaborate with different home care agencies to provide us solo care.
Yeah.
If you can speak to that.
Absolutely, yeah. So our social workers have different resource lists for lots of different things, but one of them is for agencies that provide in-home care. We work with quite a few who do an excellent job helping with that when people need 24-hour care, or sometimes it's not 24 hours, sometimes it's just nighttime care, so their caregiver can get a rest, or certain days of the week. Again, it can be expensive. And so kind of working with people to figure out what their needs are, what they can afford, and so forth is one of the things our social workers can be really helpful with. I know I'm probably getting close to my time, so I wanted to just talk a little bit about our palliative care program, Austin Palliative Care. And this is a community-based program, so we go into the home again, and the guidelines are not as strict. So palliative care is really for people who have an illness that cannot be cured, when they're having symptoms that are burdensome, or there's stress from their illness, or caregiver stress. And this is also paid for by Medicare, and it's or other payers, and it's our team is also multidisciplinary, like I mentioned with hospice. The palliative care team has a physician, nurse practitioners, nurse, and then we have some help from social work and chaplain. Those disciplines typically are just over the phone, but the physician and nurse practitioner can come into the home to do visits, typically about once a month. And we are available by phone 24 hours a day, but there's not a nurse available to come in the middle of the night. So sometimes that's a reason people choose hospice compared to palliative care. And while you're receiving palliative care, it's basically an add-on service. And so people can continue to receive life-prolonging care like chemotherapy or dialysis or other therapies that might be a barrier to hospice. There's no barrier at all with palliative care. And what I see is that a lot of times people are having symptoms that are hard to manage, and having palliative care really helps them get those symptoms under better control, even outside of hospice. The other piece is the palliative care team is really helpful at helping people navigate the healthcare system and the decisions that they're facing, and try to anticipate what kinds of decisions might come up. They collaborate with people's primary care physicians and specialists so that they try to kind of help the team of providers taking care of the person function better altogether. And there are other companies that have palliative care programs. I would just say it's one of these things where hospice is pretty well defined by Medicare, what the rules are, what disciplines are required, and what kind of level of care people are expected to receive. For palliative care, there aren't the same kind of guidelines, and it's a little bit, I was going to say like the wild, wild west. So many palliative care programs, it's really just one nurse or nurse practitioner who goes into the home, and they might be really excellent at what they do, but they may or may not do prescribing of medications. They may or may not have 24-hour after hours care available by phone if there's an urgent question. And so it's just something to kind of be aware of. And if somebody is kind of perks up their ears at all about palliative care, know that you can always just be referred to this or can call Hospice Austin, and we'll help you get to the people that you're wanting to meet with. And
But that has to be paid privately by the patient.
it's paid for by Medicare, but for palliative care, there can be a copay. Just like another clinic visit. But it is paid for by Medicare and most other payers. Yes.
I'm going back to hospice.
Yeah.
I have several people with dementia who are in hospice. And I have a hard time kind of understanding. They don't appear to be ill, and they may well live, they've been for 10 years. with dementia, but they are in hospice.
Yeah.
I'd like to understand a little better how that works.
Yeah, so, there's, with people with dementia, typically they qualify for hospice when they're losing weight or having, infections like urine infections, pneumonia. If people swallow things the wrong way and they get aspiration pneumonia, those are common things, or sometimes it's a combination of their dementia and other illnesses they have, like heart disease or lung disease. And sometimes they've been hospitalized or they're declining pretty quickly. Certain kinds of dementia, I wouldn't say easier. It's not easy to decide how much time they might live, but it's easier like with Alzheimer's disease. But other kinds of dementia, it can be much harder. The way it works is a physician at the time of admission to hospice says, I certify, I think this person has a likely prognosis of less than 6 months. And then, and whoever's referring that person also agrees with that determination. And then every 90 days for the first 6 months, and then every 60 days, a physician makes that same assessment and thinks the same thing. And what we find is sometimes each time we say, you know, when I look at this person and kind of their weight or their kind of their muscle mass, how much they're eating, how much they're sleeping, what their functioning is like, I still think I wouldn't be surprised if they died in the next 6 months. And sometimes they just keep living. And we've had people who have been on our service for 2 or 3 years. And I reviewed one recently, and the team was just wondering because they've been on with us for so long. And I said, like, sometimes I'll think about, if I go to bed tonight and I think about this person, would I feel like I would feel kind of sick if I thought of them not being on our service, because I just think I feel like something's gonna happen. And because prognostication is as much an art as it is a science, and I do trust my gut on this. And so there are definitely people who can live for a long time who are quite sick with dementia. But usually if we're seeing signs of decline, we can justify keeping them on, but it can be quite tricky. Yeah, yes.
My best girlfriend is in this situation. How do you get someone who has dementia to agree? Because they are not going to admit anything.
To agree to hospice or just that,
Well,
yeah.
because they're losing a lot of weight, they're functioning, they can still do some things, they're
Right.
certainly acting like a normal person, but they're so not, because the weight is just gone, the muscle mass is completely gone.
Right.
And she's happier than all of us put together, but she also can't remember 5 seconds. And she can drive one place, but that's it. So how do you get a person with dementia that is so declining?
Yeah.
And there is no family to back it? How do you, or do you not?
Well,
You just wait for something horrible to happen.
I never, and just if that's a perfect question as we're talking about advanced directives. We never want to wait for something horrible to happen if we can try to avoid it.
But if they will not take help, they will not.
Right,
do it,
it's hard if
they
people
have
won't
this-
take help, and they do, as long as they have the ability to make decisions for themselves, people are allowed to make bad decisions. We see that all the time in people with no illness. That people make bad decisions. So, and some people value independence and privacy above everything else. And we definitely see that. I mean, what I'd say is sometimes palliative care is an easier sell. And sometimes it can be family or friends saying, I'm so worried about you. Would you let me just have them come see you once and just kind of see what we can do to help you be safe at home? And, something like Capital City Village is a great resource for someone who is really prioritizing being independent and staying at home. So kind of thinking about what other resources, and with palliative care, because we have a social worker for that service as well, that can sometimes be helpful for thinking about what else could be helpful. And sometimes guilt or love, expressing love doesn't motivate people. And I mean, worst case, sometimes you are waiting for something to happen, but it's a terrible feeling when you're waiting for that for someone you care about. It's really terrible. Yeah.
Thank you.
Just curious if you're using geriatric massage in your palliative care or hospice care?
That's a great question. Are we using any geriatric massage? So on the hospice side, I don't know that we have anyone who's certified in geriatric massage. We do have some massage therapists and lymphatic massage therapists. On the palliative side, you know, if people